I think essentially the very, very, very short summary is that competition is great for some services and it's less good for other services. And essentially this page is an attempt to summarise that. And what we would argue is that for some services where they are essentially relatively small scale, in other words, you can provide them in an efficient way to a population of 30, 40, 50,000, then those services are highly amenable to competition. Whereas there are other services, particularly some of the more acute services, particularly some of the more complex services, where the scale factor is quite significantly higher. You're looking at population bases of around 400,000 or 500,000 to safely provide those services, and therefore it's far less amenable to competition. So in some ways a fairly simple story, but I think one which doesn't necessarily come to the fore, and therefore we get quite a lot of heated debate about competition where people throw in a number of the different arguments to it. Just to add a bit of data to this, if you start to then essentially lay on different services onto a grid, and as you can see here, we attempted to say here, where do we think there is potential to increase competition versus, do we actually have any competition in these services? The area that we would argue the government, payers, policymakers should be particularly focused on are those services which we'd say are highly amenable to competition because they don't require scale, because there's information where people can actually choose, they can look at the difference in quality, they can look at the difference in cost, and therefore we should actively be encouraging more competition in these areas. And just to identify a couple, I think diagnostics feels like an obvious one. It was interesting that about 7 or 8 years ago, there was a small policy group somewhere around number 10 that was looking at developing a voucher system for diagnostics. The idea being that you'd send, every time a woman was due for a smear test, she'd be sent a voucher and she could then choose where to go and have a test done. Similarly for anyone who was referred for an X-ray. Those various things were seen to be things that would really help to start to initiate a more dynamic system, would drive up quality, would reduce cost, and yet never really quite took off. And instead, a lot of the discussion instead focused on the reasons why not to have competition, which were essentially a number of arguments primarily about more complex services. So we would say that there's plenty of scope to increase competition in a number of discrete services. And I think the sort of key area of interest is really around primary care, where in theory, we have a system which encourages competition, but we don't actually make that work, and I'll just come back to that in a minute. There are some examples of people starting to do things differently. A couple of the notable ones were the very high-profile example in Derbyshire several years ago, where United Healthcare came in and started up what was seen as, at the time, shock horror, a private GP practice. One of the things happening at the moment, which I think many people are often quite surprised to hear, is that this has continued to a degree. So people like Assura, who are now owned by Virgin, actually involved in the running of GP practices that cover 3 million people. You've got The Practice, a group in Buckinghamshire that recently bought out Chilvers McRae. You've got Care UK playing a role in this. So there are people who are starting to come into the marketplace. And indeed, many people would say that the new entrants, the new models of primary care are actually delivering a much better quality service. Another example, which I'll come back to in a minute, is one from Spain, where interestingly, the government introduced competition for integrated providers. So that's not an either or, that's a both and. And the data from Spain suggests that introducing competition and introducing integration have actually combined to produce a much better quality, lower cost system. This is the data from Spain. So this is in Valencia. It's a specific district in Spain, and essentially the government invited a number of private sector companies to come in and provide healthcare. And they provide healthcare that covers everything from elective care through to non-elective care, through to primary care. And the data suggests that they can provide that care at a lower cost overall, and that they are getting that lower cost through a mixture of providing better quality care outside of hospital and therefore lower rates of admission, but also, interestingly, through having more efficient hospital-based services. And the theory is that the competition encouraged them to think through how can we provide the most efficient service, so hence they've got they've got relatively short lengths of stay, they've got relatively high throughput through their operating theatres, but also better quality in terms of providing better services for people out in the community. And where I just wanted to finish was to say that if we believe that competition can have benefits in some services and equally integration can have benefits in other services, what are some of the things that need to happen to actually start to make this a reality? So the first is in terms of actually changing the market structure, you need to have people who are going to be willing to compete. And at the moment, we're slightly struggling to do that. It is starting to happen in primary care, not particularly clear that it's happening in hospitals. And I think despite all the talk about bringing in private sector providers to take over failing hospitals, we're probably down to about, at most, 1 or 2 organisations that are interested in doing that. So there's a real need to try and encourage more entrants into the market is the first one. The second one is that there is to explore areas where you can actually pull out some specific services and then have a tender for those. So examples of that would be particular elective services, but also no reason why you couldn't tender out specific long-term conditions. So there are companies in the States that provide care for people with diabetes, other companies that provide care for people with coronary heart disease. And a very interesting example of this is in Liverpool, where the main tertiary cardiac hospital in Liverpool recently bid for and won the contract to provide heart failure services in the community. So they could provide that service at the lowest cost and to the highest quality, and they're very passionate about the fact that they won that tender, which they would argue was a sort of open competition tender. And again, it provides an example of competition and integration because they're integrating the community services with the hospital services. So those are some of the things about changing the structure. Perhaps more importantly is a bit about changing the market dynamics, and the really big thing here is about having more information available. So a few years ago, which is partly what spawned this article, we did some work with a number of PCTs in the East Midlands area and started to look at some of the data that you could find in terms of cost and quality. So looking at things like obesity services, smoking cessation services, core primary care services. And not surprisingly, there's a vast difference in terms of the unit cost of those services and in terms of the quality, and pretty much no correlation between high cost and high quality, in fact, probably the inverse. But you need to start to have that information available in order to have an active tendering process, in order to think through who we're actually going to purchase the services from. So you need to have that, you need to make that information much more freely available, but also critically you need to remove some of the barriers. And I think as many people in this room would acknowledge and indeed articulate, particularly in primary care, this ought to be a service very amenable to competition, and yet we put in place numerous barriers to prevent that happening. Barriers from everything from the form of insufficient information, through to restrictions on list sizes, through to the minimum income guarantees, and so on and so forth. And so previous governments have all tried to address some of those, but often fallen into difficulties with the BMA, and it'd be interesting to see how far this current government goes. So that's all I was going to say, slightly hedging my bets, neither one or the other, but say why not have lots of both. Thank you.